Hi everyone, this is my presentation, second take, an overview for medical professionals on assessment and intervention for dysphagia. So a couple of definitions: deglutition, basically it's just swallowing; hypopharynx, it is the inferior most part of the pharynx, so it's base of tongue, folliculae, inferior surface of the epiglottis, piriform sinuses, and tongue root. Endolarynx is made up of the true vocal folds, false vocal folds, and laryngeal surface of the epiglottis. The UES is upper esophageal sphincter. It's the closest upper part of the digestive system. A bolus is a mixture of food material and saliva that's been prepared for swallowing, and dysphagia is a medical term to describe swallowing in difficulty or insufficiency. So normal swallowing is broken into 4 stages: oral prep stage, and that's where we chew; oral stage, and this is where the swallowing is triggered; the pharyngeal stage, and this stage many things occur, and it's in an effort to protect the airway and move the bolus towards the esophagus. And esophageal stage is when the bolus is carried through the upper esophageal sphincter and LES, and it enters the stomach. So there's just a brief description of all the stages. So like I said, oral stage, we prepare this food. Oral prep stage, we prepare the food. The oral stage, it's voluntary, lasts between 0 to 9 seconds, and this is where the tongue provides an incline for the bolus. Pharyngeal stage, many things occur: velopharyngeal closure, a hyoid bone and larynx move forward and upward to protect the larynx; laryngeal closure, also to protect the airway; and upper esophageal sphincter opens, and this is to enhance the coordination between pharyngeal movement and the UES to complete bolus transfer into the esophagus and into the stomach. Then there is the esophageal phase, and they have 3 different zones: proximal, middle, and distal, and each have different muscle makeup. And the food goes into the stomach via the peristalsis wave. This is involuntary and takes approximately 8 to 20 seconds to complete. And once the bolus reaches the stomach, deglutition is complete. So we have dysphagia, which is disordered deglutition. It can happen of all the stages, and it's primarily prevalent in the geriatric population, and can be from motor, behavioral, or sensory deficits, or all 3, and it is bolus dependent. And premature spillage is therefore bolus dependent events, and premature spillage is when the bolus falls into the pharynx before the swallow is triggered, and that is attributed to poor tongue control and coordination. Pharyngeal residue, and this is when material remains in the hypopharynx after swallowing has been triggered, and it's more than a coating, it's flowing, it's dwelling, and it's indicative of poor bolus clearance. Laryngeal penetration, the bolus passes the hypopharynx and enters the endolarynx, and does not, however, this doesn't pass the true vocal folds. Aspiration is when the bolus passes the true vocal folds. There's 4 times the person can aspirate: before, during, at the height, and after the swallow. Before is due to premature spillage. During is due to reduced laryngeal elevation and epiglottic retroflexion. At the height of the swallow, it is due to poor laryngeal closure. After the swallow, it is due to residue in the hypopharynx. It just falls in. There's silent aspiration, which can occur with any of the 4 types of aspiration, and this is when no cough or throat clearing is, or any indication to clear bolus from the airway. This is the most severe form of aspiration. There are different etiologies, and dysphagia always occurs to a pre-existing condition. It's secondary to a pre-existing condition. Can occur with strokes, ALS, cerebral palsy, Parkinson's, and many other conditions, and the site of lesion can depend and impact the severity and what stage of swallowing is affected. So the one that has most involvement is, and the most common, is the insula. Brainstem has a huge incidence for dysphagia because of the swallowing center of the brain is located in the brainstem, with the nucleus tractus solidaris and the nucleus ambiguus, which is called the swallowing center. There are 7 clinical indicators based on research that have proven their reliability to indicate dysphagia. It's dysphonia, dysarthria, abnormal volitional cough, abnormal gag, cough after a swallow, abnormal tongue movement, and voice change after a swallow. Possible dysphagia complications. Dysphagia can have complications due to the swallowing insufficiencies and aspiration, pneumonia and pneumonitis, choking, near like choking, dehydration, weight loss, malnutrition, and other respiratory conditions. So the number 6, there could be like physiological lung changes. And there is assessment, and there's non-instrumental type of assessment. Sorry. SLPs assess with instrumental and non-instrumental exams. The clinical bedside exam, also known as a CES, is a non-instrumental method for assisting in diagnosis of dysphagia. Should not be used alone. It really should be used with instrumental assessing because it only has 40% of aspiration is not identified with the CES. So it has steps. So you really have to know steps 1 through 4 before walking into the examination room. Know if they're alert, know if they're on medications, their reason for referral, medical history. And you want to know how they sit, their posture, if they have glasses or hearing aids, their dentition. You have to do an oral exam, do a motor sensory functioning. You have to assess their vocal quality. So with ahs, e's, and high to low pitch ranges and low to high. You have to assess their respiration. Are they on oxygen therapy? Do they use a mask, nasal cannula? You have to also check their pre-oral feeding status. There is an oral and pharyngeal phase to assess in this clinical bedside assessment, but you only use if your findings indicate that they are a candidate for food assessment. If they're a PO candidate, they could take food by mouth. Just checking my time. Assessment and we have instrumental assessment. So there's different types. There's the VFSS, which is video fluoroscopic exam of swallowing, fiber optic exam of swallowing is number 2, the FEAST. Then there's the FEAST that has a sensory component, pharyngeal manometry, scintigraphy, ultrasound, EMG, cervical auscultation, and pulse oximetry. There are other approaches as well unlisted. I will go into the 2 starred ones, number 1 and 2, because they are the most common. So the VFSS allows visualization of all 4 stages of swallowing. So we coat the food in barium, and we use a fluoroscope to see how the food is swallowed, and helps to find the best eating strategies for a patient. And this lets us understand why instead of just how someone aspirates. And we videotape it so we can refer back and watch. It can be done only with 1 swallow at a time, though, because it does emit a low dose of radiation, and average radiation exposure time is 3 to 5 minutes. Fiber optic and endoscopic evaluation of swallowing, that's also known as a FEAST. It's a comprehensive exam with 3 parts. You assess the anatomy and physiology, you assess swallowing on food and liquid, and assess their response to therapeutic intervention. So you could actually see what intervention would work best while you're assessing. This is done by positioning an endoscope right above the endolarynx. You could visualize the larynx and the moments of aspiration. You could see the secretions, the residue. Can be done for longer periods of time with full meals and has no radiation exposure. So, and this is also nice, the family could be present. Sometimes families are a little bit in denial, and this allows them to see the actual deficits and moments of aspiration. This can be done also with NPO patients, unlike the VFSS. Sorry, I needed water. Can be done with NPO patients that are aspirating on their secretions with the ice chip protocol. So there's treatment and management for dysphagia. Treatment, we're addressing the deficits, and we exercise with therapy and attempting to lessen the cues that we give and create less symptoms. I have to fix that, but we create less symptoms of the dysphagia, not more, less. And we have 2 types of treatment, direct treatment and indirect treatment. And basically they're the same, just direct treatment involves food and indirect treatment is without food. And this is therapy to the anatomical structures used in swallowing. So breathing exercise, oral motor. Managing is different. Management, we're providing compensatory strategies for eating. So this can include textural changes, increasing sensory information like a carbonated bolus, adaptive equipment like the bowls with a higher lid for people with one side paralysis, repeated swallows of cues for repeated swallows of bolus of one bolus to clear residue, and change of mealtime environment. And one is more addressing the actual motor, like kind of trying to reduce the deficits, and one is just managing and offering compensatory strategies for the deficits. So there's treatments that we could do. There's postures that a patient can do to facilitate swallowing. It can be used for different types of dysphagia, not for long-term use. Some patients are not candidates for these postures. These postures include the sitar, which is the chin tuck against resistance, the chin up posture, the shakir, the head rotation, effort swallow, and definitely more. Their efficacy is based on peer-reviewed research. There are exercises that can strengthen overall musculature. So there's LSVT loud. This is typically for Parkinsonian dysphonia. However, it has shown to improve and strengthen swallowing structure and physiology. You could do tongue crawlbacks to strengthen base of tongue, the IOP and the modified IOP to strengthen, and these are tongue and lip resistant exercises. My conclusion: dysphagia can occur with all age groups. It occurs as a consequence to an overarching condition. Assessment and intervention is highly individualized. And you must assess each patient with their deficits and their own needs in mind. So you really have to look at your patient one by one, and you can't use any one single approach in diagnosing and treating aphasia. Like what one will work for one patient might not work for the other patient, or might actually be detrimental to the other patient. So you really, really have to case-by-case basis with your assessment approach and your intervention approach. And SOPs must be up to date with the literature and use evidence-based practices and techniques in assessing and treating patients. Thank you very much.